Minister, thank you very much for joining us here at Just Mental Talk. Before we delve into some of the challenging questions and issues around mental health, I'm keen to find out a bit more about Mike Nesbitt, the person, Mike Nesbitt, behind the MLA and the Health Ministry, and what drives you and your passion for the roles that you do on a day-to-day basis.
Well, Carl, I suppose my my background is not a straight line into politics. Many years ago, my paternal grandfather started a linen business in Belfast, which he handed down to his two sons, Uncle Jack, who was about 13 years older than Dad, and they took up the business, but in late January 1973, it was blowing up in part of what we so euphemistically call the Troubles. And Uncle Jack was well into his 60s by then, so by the time the compensation money came, Dad couldn't get it going again with half the money. And I think that's what got me interested in the human cost of conflict and the politics of Northern Ireland, because in the moment of that explosion, I think every certainty in Dad's life disappeared because he had been brought up to take over from his dad. And yet all the responsibilities of being a husband and a father, running a car and a household, they were all remaining. And suddenly the income stream had disappeared. So, as you probably know, I went into journalism. I was covering the politics and the human cost of our conflict. And then I went into the Victims Commission, helped to set that up in around 2007. And then that led to getting on the other side of the table from the politicians and being a politician. So it's kind of a bit of a windy, but there is a bit of a thread there.
Yeah.
And within that comes the interest in poor mental health and well-being, right back to the impact on my dad, who was 49 on the day of the bomb, being a victims commissioner, and also my wife having an episode of clinical depression. All those kind of life experiences have given me a focus on based.
And in light of that, Minister, and thank you for sharing that with me, but in light of that, when we hear on World Mental Health Day that the mental health strategy, which sat on the shelf for so long, then to be implemented, and then to be told on World Mental Health Day, do you know what? Actually, we don't have the funding for this. What sort of message do you think that sends to people who are currently sitting in crisis, or people like myself who are still very much on the recovery journey? Because for me, it makes me feel as though, okay, well, maybe my illness isn't important then as some other illnesses out there, or my recovery journey is not as important as some other people's recovery journey. So how do you think that makes people feel sitting at home right now who are really struggling with their mental health? And what hope can you give them out of that?
I would imagine very shocking. I imagine it's very shocking if you're in that position. In the same way, if you are worried that you may have breast cancer because you've discovered a lump, to be told that the waiting list isn't the kind of 14 days that we have set as a standard, but is maybe 8 weeks, it's absolutely shocking. And I just hope people can take a kind of broader view of it and understand that this is just reflective of the huge gap between capacity and demand. We simply don't have the capacity to meet demand in a timely manner, and that's right across the board. And you look at our waiting lists, which are several years in so many specialisms or specialties. And so I just hope people realise that there is a big problem in terms of the funding and the resource of the health service. And so to make a broader point, if I may, Carl, when Stormont came back early last year, the argument that we collectively made as local politicians to the Northern Ireland office and to Treasury was that the Barnett Formula wasn't fit for purpose, because what it does is take a crude head count and say we're roughly 3% of the population. So when they spend 100 million in England, we should get 3 million here. And we said, no, instead of doing that crude head count, let's do it on assessed objective need, because our needs are different from England, not least, for example, in poor mental health, because it's a population legacy issue of the troubles here, not so in England. And yet, when I make this, and we're very successful with that argument, instead of pound for pound with what's been spent in England, we now get £1.24 for every pound spent in England. But when I try and make the same argument around the executive table to my colleagues in finance and the First and Deputy First Minister's office and education and the rest, that we should be doing this on objective need, they say, no, you've got just over 50% of the budget. And crudely, they're basically saying, just get on with it. But actually, it's a bit of a red herring, because on objective assessed need, we actually need more money.
So would you say, in light of what you just said, would you say then your executive colleagues don't value mental health, or indeed the health needs of Northern Ireland the way you do?
Well, I think what they do is they realise that they have extreme pressures as well. Whether that's in education or in infrastructure or in agriculture, the environment, rural affairs. No minister and no department has the level of funding that they think they need to do what they want to achieve. I think the difference, which I think probably is well understood, is that if we look at, for example, infrastructure, potholes need fixed, because potholes can wreck your suspension on your car. But they're not going to kill you. Whereas in health, if we don't get it right, people do suffer, and can suffer extremely, extremely badly.
Yeah.
I suppose the other point, because this is very relevant, what you're discussing with me, Carl. You know, I campaigned on mental health from when I was elected back in 2011, and when Robin Swan took the ministry a few years ago, he did two things that I really wanted. One was to appoint a mental health champion,
yeah,
and the other was to bring forward a 10-year mental health strategy. And that strategy is world-class. It's kind of gold-plated. And the same would go, for example, with our cancer strategy. But the fact is, we don't have the money we need to implement it in full. So for the mental health strategy over the 10 years, we reckon we needed £1.2 billion.
Mm-hmm. That's right.
And we have not been able to access that. We won't be able to access it. And so we've had to take a more pragmatic view and say, well, within that strategy, these are the key priorities for this financial year. And that's where we're going to put the limited pot of money that we have. And perhaps that wasn't the best way to approach things, because, as you suggest, maybe we raised hope to a level that we can't satisfy. And that's not necessarily a good thing. So my preference would always be, give me a costed one-year action plan over a 10-year strategy that we can't afford to fulfil.
So where does the mental health strategy lie now? Is it that at part and the only parts that will be implemented? So where does the mental health strategy for Northern Ireland lie currently?
Well, it lies in that sense of saying we cannot do everything that we were hoping to do in terms of delivery. So what we're going to do is going to look through the 35 actions that we have in the strategy, and we're going to decide which are the priorities that we can actually deliver in the next number of months.
Minister, when you say looking at that, we are going to look at that, is there any involvement there from people who are currently going through their journeys, or is this led just by your department? Because I think you yourself have acknowledged in the past the importance of having people with lived experience involved, and we see that in the Trust with peer support workers, with the likes of the Belfast Recovery College, etc. So will people who it affects be involved in this process?
Yes, is the short answer, because I'm going to take you back, Carl, to something that Professor Raphael Bengoa said to me when he came back in October of last year. I invited him back to effectively reboot that report that he published back in 2016 called Systems Not Structures. And what he said to me was, you need, as minister, you need to be really tight about what you want to achieve, but you need to be really loose about how you achieve it. So if I say I want to do something for our shockingly bad rates of poor mental health and well-being on a societal level, on a population level. I'm not a clinician. I'm not a service user. So I don't know the answers. So I need to be loose and say to people like you and to the clinicians and the people you're working with, what are the issues? What are the solutions? What are the obstacles? I always find as a politician there are three questions that I should be asking somebody like yourself. Number one, what are we doing as a department that is helpful? Number two, what are we doing that hinders you from getting to where you need to be? And number three, what are we not doing that we should be doing? And I think if you get the answers to those three questions, you're a long way towards delivering the right sort of service.
You mentioned there about the specialisms and certain specialisms waiting in sometimes years, unfortunately, for diagnosis. And one of those specialisms that has seen a huge increase in the past number of years is that of the ADHD. And there's still a huge amount of adults waiting quite a long time for diagnostics. Is there anything that can be done to address the gap in that process for being diagnosed as ADHD? Or what is currently being done?
A couple of things on that. ADHD is a growing issue in terms of population health, and we have no commissioned services across Northern Ireland, so there has been an almost ad hoc reaction across the 5 geographically defined trusts as to what they do. That's not good enough. So what has happened is there's been a commission for some research. Tell us about the demand for ADHD currently. Give us your best guess, projecting what the model is going to look like, what is needed in future years. And that will give us a baseline for developing a commissioned service, both for children and for adults. And that's where we are at the moment. And that report, I am assured, will be with me before this month is out. And that gives us the baseline, but then we need to discuss with service users, we need to discuss with practitioners, how do we design a best-in-class service.
Back of that as well, does that report also look at the likes of the shared care and GP involvement? Because we've seen that because of the huge waiting list on the NHS, there are those people who can afford to go private to get a diagnosis, but when it comes to being prescribed medication, which the GP must do, the GPs are reluctant to enter into the shared care agreement. Why are so many GPs declining these arrangements, and what do you think that can be done to ensure patients can get the right medication?
First of all, I do understand that some people are going privately because they love their loved ones. And it's not necessarily because they can afford to go privately, because they will sometimes go into debt to achieve that. To my mind, it's wrong that they would even have to touch their savings for this, but they're doing it because the system isn't operating as efficiently and as quickly as they believe they need for their loved one, and absolutely get it. So they go privately, effectively reluctantly, but because they feel they're being forced to do that because the health service isn't there for them in the way they expect and deserve. And then they find that there's a private prescription which they take to their GP, and the GP is reluctant sometimes to sign off the prescription, and indeed, anecdotally, it seems increasingly refusing to sign off the prescription. And we need to better understand that. We know that the person who signs the prescription is ultimately responsible for it. So they shouldn't be signing it unless they feel it's within their competence and the guidelines of their professional body, etc., etc. But there does seem to be an increasing incidence of GPs becoming so risk averse that they're refusing to sign. And one example that I found particularly troublesome was a mother had sent a child for a private diagnosis, had got a prescription, the GP had been issuing the scripts. On review, the private clinician did not change the medication. It was the same medication, but changed it from being instant release to slow release. Or it may have been from slow release to instant release, doesn't really matter. But just the same medication, different dispersal, and the GP refused to sign the new script. That was the same medication. So I don't understand the clinical basis, if there is a clinical basis, for refusing to sign that script, or whether it is just this growing sense of I don't need to do this, there's always a risk involved in signing this, I am so risk averse I'm not going to do it.
Can you do anything as Minister to change that though? Because, you know, people going private is taking a bit of pressure off the NHS, off the trusts, because they're going private, yet GPs aren't willing to work. So with that, so can you do anything to address that?
Well, if you mean, you know, can I force a GP to sign a script? No, I can't. But what I can do is ask officials to scope it out so that we better understand exactly why there is this seemingly growing reluctance amongst GPs to enter into these shared care arrangements. And I mean, I believe every GP is there to try and help their patients. So I don't think there's anything malicious there. But is there something that we can do? I'm now asking the question of the service. Is there something we can do if it is all about a reluctance to take risks? Is there something we can do to try and reassure GPs that the risk is being managed and managed in a way that would release them again to be able to enter those or maintain those shared care arrangements? So
just very briefly before we move on then, so you're saying you could ask your officials to scope it out. Have you asked, or will you ask your officials to scope it out?
Yes, I've had several discussions, a couple of discussions, I should say, with officials about this. The public sector is not built for speed, Carl, so these things do not resolve themselves particularly quickly. But yes, officials are aware that this is a matter of concern for me and that I want answers. Now, it may not be the answers that I seek that they're bringing back to me, and that it may be a sticky problem that's going to be very hard to shift. But I just need to know, rather than going on an instinct and anecdote, that it's risk aversion that's at the root of it. I want to better understand exactly what's going on.
Thank you, Minister. I want to move on now to the mother and baby unit. It's my understanding that Northern Ireland is the only part of the United Kingdom without a mother and baby unit, which means that when a child is born, if the mother's suffering from postnatal depression, and correct me if I'm wrong, and it's felt that the mother needs psychiatric care, they're placed into a general psychiatric care ward, and the baby is taken away, potentially with a father or whatever that may be. I understand that work may have commenced or a plan was developed, but that again has also been shelved. Yet we're seeing over 1,000 mothers each year suffering from postnatal depression. Where are we with the mother and baby unit? I know you have your own experiences as well around this. So what hope again, you see the hope is a consensus here throughout this interview, that what hope can you give mothers who are suffering from postnatal depression and their children are literally being taken away from them and they're left in absolute despair? Where is the mother and baby unit? When is it going to be built? Can you give an idea or a deadline of when it will be built?
I can give you the current thinking, and I think the first thing to say is that it is absolutely at the top of my list in terms of the capital projects and the capital budget. We don't know our capital budget yet, but I expect that the Finance Minister will make that clear before the end of this calendar year. In other words, in the next 7-8 weeks. There are 14 big projects on that list, and the mother and baby unit is right up on the podium. It's absolutely in the top 3. So a lot of scoping has already been undertaken. So the Belfast City Hospital site has been identified, and that's partly because it has the acute inpatient adult mental health unit. It is also close to a maternity unit at the Royal Victoria. And these things are considered best practice by the Royal College of Psychiatrists. So plans are advancing in terms of the business case for a mother and baby unit at the Belfast City Hospital. However, the projected timeline would be opening in 2032, which is 6.5, 7 years away. Yeah, so as I say, we're not built for speed. So there was a debate in Assembly a couple of weeks ago, and the mood of the MLAs was, let's have a temporary mother and baby unit in the meantime. And the mood was also to accept that there is no location in Northern Ireland where you could have a temporary unit that would meet those best practice conditions of close to a maternity unit, close to an adult inpatient mental health unit. And the MLAs were basically saying, don't let the perfect be the enemy of the good. Let's do it anyway because a temporary unit is better than what we've got. So although officials had previously told me there is no venue for a suitable venue for a temporary unit, I have asked them to go and look again, bearing in mind that MLAs seem to be saying good is better than best practice. And we are close to identifying a potential site. I have personally had some discussions with the right people about this site. And so sooner rather than later, I am hoping to go back probably to the Health Committee rather than the Assembly. And I'm going to say to them, this is what is possible. This is how far short of best practice it is. Will you sign up to it on that basis? And if they do, we can actually move relatively quickly to establish a temporary facility. And the reason it's important to me to have it up there, Carl, is from personal experience, as you suggest, because a full 30 years ago now, January in 1995, our first son was born. Linda had already been diagnosed with clinical depression, so it was antenatal. And so they were ready to start her on medication and treatment as soon as the baby was born. And Peter was born 27th of January, so it was a cold, dark, miserable winter day, born late afternoon. So by the time we got Linda back up to the ward, it was after tea time, and a psychiatrist came in, and he was pretty gruff. I got the impression we were holding him back for going from his Friday night pint at the rugby club. And he threw me out of the room because Linda was in a little side ward. Then he called me back in and he said, yeah, look, I want to move your wife to Knockbracken, but we'll keep the baby here in the Royal. And I saw the look on Linda's face, the horror at the suggestion of being separated from this newborn baby. And I don't know where I found the strength, but I suggested to him that I'd like a second opinion. And I thought, well, I'll tell you what I thought in terms of his reaction. And the marvellous Dr. Philip McGarry came and gave a second opinion. And again, he asked me to leave the room. And his assessment was, your wife is in a mental state where she thinks if a bus came along and knocked her down and killed her, that would be a good option. But she's not of a mind to jump in front of a bus. So we're going to fix this. And he brought the hope back to the situation. And mother and baby stayed together in the Royal until we went home. So I get it. She needed a mother and baby unit on the 29th of January 27th of January 1995. And 30 years on, there still isn't one available to mums in that position. So it is a personal crusade for this health minister.
I'm conscious of time, Minister, and I appreciate you sharing that with me. But before we move on, so you're saying by 2032 we should have a permanent mother and baby unit, and you've mentioned a few times that the public sector is not built for speed, but you mentioned that we should have a temporary solution quickly. What does quickly look like in not built for speed?
Okay, with a fair wind before the middle of 27. say 18 months, we could have a temporary facility. And of course, it is partly about the physical environment, because we were taking an existing building. You can be sure of that on that time scale. It would be an existing building which would be redesigned or repurposed, but it's also about getting the right staff. And you're talking about highly specialist individuals. And sometimes, often I say money's the problem. We just can't afford to spend more on this, that, and the other. But sometimes it's not about the money. It's about the workforce.
Thank you, Minister. Suicides. Northern Ireland has one of the highest suicide rates across the UK. Why do you think it is? What can be done, or what is being done? And of the over 200 families left in despair and grief in 2023 after 220 suicides in Northern Ireland, what can be done to address this appalling rate of suicides in Northern Ireland?
I think, first of all, we've got a problem, you've got to name it. And you've just named it. And we're long past the point where the number of people we have lost to suicide since 1998 has exceeded the number of people who lost their lives during the course of the conflict, the 30 years of what I so euphemistically call the Troubles. So it's intolerable. It should be an intolerable situation. And we have put a strategy in place. And we're now on Protect Life 2, the second strategy, with an implementation plan. And to my mind, one of the most important things to recognise is the correlation between death by suicide, mental ill health, and the hotspots of those troubles. Because if you take a map of the hotspots, the troubles measured by shootings, murders, bombings, and you superimpose a contemporaneous map of mental health issues and suicides, you pretty much have a map, a match. Like North Belfast would be high up the list for both categories. So I think awareness is high, and we now are taking positive actions. What I would like to see is much more community involvement. So, for example, in my own constituency, a woman came to me because she had lost her 23-year-old son to suicide. I wanted a vigil in Conway Square, the main kind of square in Newtownards, where I'm based. And she was not happy with the council, who she didn't think were paying due attention. So anyway, we got it done. We had a vigil one night. We had a lot of mental health and suicide charities dotted around the edge of the square. A lot of people turned up, Carl, and not to support her, but because they had lost loved ones to suicide. So when it was over, we were sort of debriefing ourselves, and we thought, we can't just walk away. This is an issue we've got to stick with. So we started an awareness group, and we have been into schools in Newtownards. We've been around the big housing estates. People have come to us with fundraising that we haven't even asked for, and we've used it for things like safe talk classes, which you'll be aware of, like a 3-4 hour class, which doesn't make you a counsellor, but kind of gives you the confidence to know how to intervene when you see somebody that you know is looking a bit down.
Because that intervention, I suppose, like anything, we always believe that intervention is the key to preventing. So yes, the Safe Talk initiatives with hairdressers and bar staff and things like that, I think is a fantastic initiative. And I think you are hoping to roll that out further than North Down, from what I'm led to believe.
Yes. I've been in talks with Hospitality Ulster, who of course represent all the pubs and clubs, restaurants, because we think that's a really rich area, because if you or I are barmen, we may have a number of regulars. So we're going to spot them when they come in. Carl's looking a wee bit down today, and maybe just have a word. When we took the Safe Talk, I went to one of them in one of the big estates, and afterwards I was asking people, what did you think? Was that any use? And they went, that was fantastic, because you know what? That's exactly what I do with my friends when I think they're feeling a bit down. But it was so affirming to be told by a professional that what I'm doing is the right thing to do.
Yeah.
So that we're leaving with lots more confidence than they arrived with.
So the in terms of suicides, then you're now phase 2. You mentioned how many phases are there, and what do you expect to see out of this?
I didn't like when Protect Life 2 was first published, and I wasn't minister at the time, was that it had a target which I think was reducing the number by 10%. I think was the original in the original document, which was a World Health Organization target. So I mean, it wasn't just plucked out of the air. But myself and some of the other MLAs who were on the all-party group who were being briefed, we took a view there's only one acceptable number when it comes to suicide, and that's 0. So you have to say our long-term target is 0. Because I also believe, and I think there's evidence of this, every suicide is preventable right up to the moment where it is executed. So we didn't like particularly what looked like a lack of ambition, although it was a realistic target for a time frame. So I have to accept, yeah, we can have realistic targets, but the people who are setting the realistic targets also have to accept that we have the legitimate right to say the only endpoint is 0.
Finally, Minister, because I know we're just over time and I appreciate it. What would you like to be your legacy in the field of mental health as Health Minister when your tenure ends in 18 months' time?
Hope, in one word, would be the answer to that. I want to inject more hope generally across health and social care. Because I do hear the narrative that the whole system is broken, and I don't accept that. I believe that once you get to the point where you're receiving care, you receive world-class care. I think what is badly fractured are the pathways by which you access health and social care. And to evidence that, I just point at the waiting lists, which in some cases are multiple-year waiting lists. And generally what I would like to do is make sure we're putting in place a direction of travel that the next minister is going to feel compelled to follow. Because a lot of these issues, including poor mental health and well-being, including our shocking rates of suicide, are not going to be fixed in 18 months. But in 18 months you can put in the foundations and create a pathway for the next minister to follow. And then you'll get 6.5 years through to the next election in May 2032. And during that period, you will notice positive change.
Minister, thank you very much for your time today. I appreciate it. And enjoy the rest of your day. Thank you, Minister.
Thank you, Carl. Take care.